I would like to express my gratitude to the organizing committee for giving me the opportunity to discuss my presentation about the biological features and the methods of preparation of platelet concentrates. Platelet concentrates are probably the most straightforward approach to regenerative medicine. They are prepared from a venous blood sample and have a platelet concentration higher than whole blood. In particular, platelet-rich plasma, a widely used autologous blood product, is a plasma preparation with a quantity platelet 4 to 5 times higher than the whole blood sample used for its preparation. Platelet lysate and platelet gel are prepared by platelet-rich plasma PRP manipulation. We will describe their preparation later. Platelet concentrates are autologous therapeutic preparation. It is important to emphasize that this preparation bases their function on cellular and molecular components whose concentration and functional quality are different from patient to patient. Furthermore, the preparation technique has a substantial impact on its composition. Most of the time, the user cannot determine for every single clinical preparation the precise composition of a platelet concentrate. These preparations, therefore, are conceptually very different from drugs and suffer of a low standardization. With this in mind, we should briefly say something about the reason we are using platelet concentrates in therapy. The main point is that the biological role of platelets goes much beyond blood coagulation, since they are key players in the process of tissue healing. When a vessel is injured, platelets are activated by exposure to tissue antigen and extracellular matrix. Once activated, they secrete molecules that together with the coagulation factor form a platelet plaque and then a clot with red blood cell and white blood cell trapped in a fibrin mesh. Indeed, the platelets have much more complex function. They contain various types of granules, among which the most important are the alpha granules, which are discharged into the surrounding environment following platelet activation. Platelets contain several hundreds of bioactive molecules, ion, small bioactive molecules, growth factors, chemokines, and cytokines. They are involved in several biological processes. For example, wound healing is actively modulated by platelet secretome. Signaling proteins, adhesive protein, and proteases, together with small molecules and ions that are secreted by platelets, are found at high levels in PRP. They interact with multiple cell types, for example, with cells involved in the immune response and inflammation, angiogenesis, cell migration and differentiation, and anabolism and catabolism of the extracellular matrix. Here, some of the specific effects of platelet-derived growth factors are illustrated. These are the main drivers of therapeutic action of PRP. But we should remember that when we use platelet-rich plasma and other platelet concentrates, inside these preparations, there is indeed more than platelets. This means that the biological and therapeutic features of platelet-rich plasma are not attributable to platelets only. As a matter of fact, leukocytes and other circulating cells, plasma-soluble molecules, and fibrin are active components of platelet concentrates. When we apply platelet-rich plasma, cells and soluble factors secreted by activated platelets are trapped inside a three-dimensional fibrin matrix. This fibrin scaffold has specific binding site for growth factors and retain platelets, leukocytes, and other blood cells so that they will continue to act locally. As long as the three-dimensional scaffold remains, the active biomolecules are slowly and continually released. Also, the leukocytes have a significant impact on the intrinsic biology of platelet-rich plasma. In the last years, much attention has been paid to their role, and several studies have been conducted to define their immune and metabolic effects in PRP. The white blood cells are crucial plasma components of healing processes. The therapeutic roles of leukocytes in PRP requires further investigation, but the presence and mechanisms of these cells must not be forgotten in clinical application. As a consequence, different classification has been proposed for platelet concentrates on the basis of their cellular and molecular composition. Don Ehrenfest, for example, proposed a classification that takes in consideration platelet, leukocyte, and fibrin content. In particular, pure PRP contains high levels of platelets, but is poor in leukocytes. Leukocytes, PRP, is a platelet concentrate that show a higher content of white blood cell. Now, we should consider how platelet-rich plasma is prepared. The components of the blood, plasma, and the different cell types can be separated based on their shape and density. In particular, each cell population has a different density. We can apply gravitational field to separate the different population. Please note that platelets have a lower density than red and white blood cells. White blood cells and platelets density are quite similar. In the practice, this means that it is easy to remove red blood cells from PRP, but it's not so easy to remove completely white blood cells. As a matter of fact, the preparation of PRP requires that platelets are separated from the other cellular components of the blood and then concentrated in a suitable plasma volume. We can use both commercial kits and manual methods for this purpose. They are different with regard to time needed for the preparation, instrumentation, and competence of the operator. I would say that both methods require a little bit of experience and competence to work correctly. Most of the PRP preparation techniques are based on a double centrifugation method. With the first centrifugation step, red cells and large part of white blood cells of the blood sample are separated from the plasma fraction, where platelets are instead maintained. With the second centrifugation step, the platelets dispersed in the plasma expand down to the bottom of the tube, forming a pellet that is then resuspended in a small volume, obtaining the final product that is the platelet-rich plasma. In this slide, you can see what happens to blood cells during the procedure. With the first centrifugation step, we want that most of the platelets remain in the plasma fraction, as seen here. You should note that indeed, invariably, some platelets are lost in the lower red blood cell fraction. Most of the white blood cells are concentrated in the Buffy cord, at the interface with red blood cell fraction. Nevertheless, some white blood cells instead remain in the plasma fraction. Usually, also a very small number of red cells remain in the plasma fraction. Following the first step, plasma and cell dispersed urine are collected and transferred to a new tube, avoiding the collection of the Buffy cord containing white blood cells. In the second centrifugation step, plasma and platelets are centrifuged again. In this case, the aim is to pellet all the cells at the bottom of the tube. Then most of the plasma, now free of cells, is removed, and the cell pellet is resuspended in a small volume of plasma. In this example, to produce PRP, 2 milliliters of plasma are used, starting from a 10 milliliter of blood sample. Please note that PRP will contain all the cells of the plasma fraction obtained after the first centrifugation, and hence also white blood cells and some red cells. A single-step procedure is also used for PRP preparation. In this case, a single stronger centrifugation of a blood sample is applied for a short time. Most of the platelets are concentrated just above the interface with the Buffy cord. After the centrifugation, the operator should discharge the upper part of the plasma and collect the lower third of the plasma fraction. This is directly used as PRP without any further centrifugation. This method is simple, but it usually allows a lower concentration of platelets. Here are some bibliographic references illustrating times and G-force we should apply preparing PRP with the two-centrifugation step method using dog blood. As you can see, there is an evident variability in the procedure. I suggest you to read the paper from Shin and colleagues, since it is an exhaustive study about the preparation of PRP in the dog. Here are some data about the single-step procedure used with dog blood sample. Again, the variability in the procedure suggested is clear. But which are the advantages of the manual methods? The first advantage of the manual method is that it is a low-cost procedure. Only some tubes and sterile pipettes are required. The possibility to modify the volume of a blood sample used for the preparation is quite useful, especially if repeated administration are needed. The volume of a blood sample, of course, depends on the size of the animal. The final volume of the products is instead a function of the protocol and of the initial volume of the blood sample. For example, usually 2 to 3 milliliters can be prepared from a 10 to 15 milliliter sample, up to 20 milliliters from 100 milliliters of blood sample. Which are instead the disadvantages? The manual procedure is not a closed system and thus exposes to risk of environmental contamination of the products. So a sterile hood is strongly suggested, or better, is indeed necessary. Furthermore, the operator needs to achieve an adequate manual skills that are usually not necessary using the kit. As an alternative to manual methods, many kits are available to prepare platelet-rich plasma. For example, in the United States, about 50 different kits are available. There are different approaches for different kits. Some of them use double centrifugation or single centrifugation step. Some other use filtration. There are multi-step or single-step systems. Most of them are closed systems. 2 points are of interest for the clinician. Unlike a manual technique, the kit usually does not allow to change the volume of the blood sample and of the final PRP. Therefore, these parameters must be carefully evaluated based on the desired application. For example, if you need two intra-articular application in a large breed dog, and the kits allow you to get 2 milliliters of PRP, you will probably need 2 kits for the therapy. Of course, the features and the protocol of a kit must be appropriately evaluated before the purchase. This brings us to the critical point. Which parameters do we need to assess the quality of PRP? There is a consensus that PRP should contain 4 to 5 times more platelets than the initial blood sample. We can also translate this in a number. Platelets in PRP should range from 0.5 billion to 1 billion per milliliter. Keep in mind that the mean platelet count is different in different animal species, and there is also variability between different breeds. To assess the efficacy of the procedure, you need to know the number of platelets in the blood sample and the number of platelets in the final PRP, so to calculate the percentage of platelet recovery. White blood cell number is an additional parameter of the preparation. White blood cells should not be concentrated in pure PRP. Which are the advantages of the commercial kit? The kit manufacturer provides materials and tools necessary for the preparation. Simple manual skills are usually required. PRP production takes place under sterile conditions. The results are usually repeatable. Which are instead the disadvantages of this technique? There is limited possibility to modify volumes and operating modes. Often is needed to buy dedicated and expensive instruments. To repeat the preparation, a new kit is always necessary, so that the cost of the preparation can be significant. Platelet-rich plasma is a liquid preparation. It can be used fresh, just after its preparation, or can instead be stored, obtaining a so-called platelet lysate. The more practical way to store PRP is freezing it at -20 or -80 Celsius degrees. Later, when the preparation is used, it will be thawed and applied. This cycle of freeze and thaw determines the rupture of platelets and the release of growth factors into the plasma. This product is called platelet lysate. Platelet lysate is useful in the clinical practice since the clinician does not have to prepare a new PRP at each application. It should be noted that all the content of the platelets are one-shot released by freeze-thawing cycles, while the application of PRP determines a slow release of the growth factor. PRP is in liquid form, we said. Sometimes, for example, to promote wound healing, a solid form is useful and is prepared. This form is the platelet gel and is usually prepared by inducing the gelification of PRP or platelet lysate by adding calcium salts to the preparation. Restoring calcium concentration induces the coagulation of PRP and the formation of the gel. When applied, the gel provides its load of bioactive molecules to the healing tissue. Furthermore, it creates a three-dimensional matrix that acts as a support for cell migration and differentiation, thus actively contributing to tissue healing. With time, tissue-resident cells will populate the scaffold and fibrin mattis will be gradually degraded and substituted with new tissue. Platelet gel can be easily manipulated. Its shape, dimensions, and thickness depend on the support we use for its preparation. Biocompatible supports can be used to give strength to the gel so that manipulation is more comfortable. Here are some concluding remarks. Platelet-rich plasma is becoming an interesting therapeutic option in veterinary medicine. PRP contains a variety of bioactive molecules and cells that provide a regenerative stimulus and control of local inflammation of damaged tissues. Different approaches are available for PRP preparation, and that clinicians should be aware that different preparation methods can produce different products, so that a careful study of the available alternative is suggested before to decide the best approach to PRP preparation. Thank you very much for your attention.
Brilliant. Thank you, Stefano, for your talk. We now have time for some questions for Stefano. We have had a question come in, Stefano, and it says, have you considered the ratio of platelet leukocyte number in PRP sample? Isn't a high leukocyte detrimental to the anti-inflammatory action of PRP?
Well, first of all, it's quite clear that I am not an English mother tongue, so I'm not using a very fantastic English of Wayne and Laura. With regard to the question, the ratio between platelets and leukocytes in PRP, it's indeed a key point. As Laura said, there are some applications where leukocytes maybe are useful. For example, in wound healing, the apport of antibacterial molecules and pro-inflammatory molecules by leukocyte, especially in the first phases of the wound healing, is considered an interesting and positive effect. But sometimes, for example, when you apply PRP inside a joint in osteoarthritis to introduce a high number of leukocytes can be detrimental for the tissue, and especially it's painful sometimes, the inoculation of leukocyte platelet-rich plasma when joints are excessively inflamed. I have answered the question, but I was not sure of the last part of the question because there was some problem with audio.
Okay, the last part of the question was, wouldn't high leukocytes be detrimental to the anti-inflammatory action of the PRP? I think you've kind of touched on.
As I said, this is true sometimes. If you need, for example, to promote wound healing, you can use in the first time of the process a leukocyte-rich PRP to induce inflammation and to stimulate the antibacterial properties of your preparation. And then when the tissue is going to heal, it's better to use a pure PRP where a low number of pro-inflammatory molecules is a better signaling system to wound healing.
Brilliant, thank you, Stefano. I just have one more question come in, and it says, is a pre-activation step needed to enhance PRP efficacy? And if so, what would be the best strategy?
So we said that exogenous platelet activation is often applied before clinical application because we need to induce cell degranulation and growth factor release. As Laura said, there are different methods to activate platelets. Some methods are physical, for example, freeze and thaw cycle, and some are chemical methods, for example, calcium salts and thrombine that are routinely used also in veterinary medicine. It is quite important to decide which strategy to use because it has been demonstrated that the activation protocol can indeed affect growth factor and cytokine release. For example, in dog and horse, calcium gluconate and calcium chloride do increase growth factor in PRP with respect to non-activated PRP. I probably didn't mention in my presentation that the suggested anticoagulant to collect blood sample for the preparation of PRP are citrate salts. They bind calcium so that you can restore coagulation and activate platelets simply adding calcium salts. Sometimes thrombine is used, and it's worth considering that commercial thrombine preparation are usually from bovine or human sources. So they are xenobiotic, so they possibly can induce undesired reaction. With regard to the freezing and thawing of PRP, Laura said that it's a quite useful approach, but you have to remember that indeed is different, the biology of the two preparations. Platelet freezing and thawing, as a matter of fact, results in cell rupture, so that all the load of platelet growth factor is released into the plasma and is immediately available. On the contrary, if you use activated PRP, platelets can synthesize and secrete growth factor probably for a few days. So the application of fresh PRP may allow continued production and release of this growth factor, and the action is supported for an extended period. A final consideration that I would introduce is that indeed exogenous activation may not be necessary, since when platelets are exposed to tissue collagen or calcium salts present in the tissue in the environment where PRP is administered are per se an effective stimulus to platelet activation. So in other words, not activated platelets may release growth factor since they are activated when they are applied at the site of the injury. Laura talked about how long the storage of PRP can be suggested, so I don't talk about this topic.